Food allergy describes an adverse immune-mediated response, which occurs when a person is exposed to specific food allergens, usually by ingestion and more rarely by inhalation or skin contact. Cow's milk allergy is a reproducible immune-mediated allergic response to one or more proteins in cow's milk. Milk contains casein and whey fractions made up of about 20 potentially sensitizing proteins, which a person can react to. Food sensitization describes the production of serum-specific IgE to food allergens without the clinical symptoms of an allergic reaction on food exposure. Food intolerances are non-immune adverse reactions to foods and/or food additives which are distinct from food allergy. They often present non-specifically with gastrointestinal symptoms, headache, fatigue, and musculoskeletal symptoms. Typically, there is a delay in symptom onset and a prolonged symptomatic phase. The exact cause is unknown, but they may be due to enzyme deficiencies or pharmacological reactions to chemicals. Cow's milk allergy can be classified according to the underlying immune mechanism and timing of symptoms. Immunoglobulin IgE-mediated food allergy follows exposure and sensitization to trigger food allergen with the development of serum-specific IgE antibody. It produces immediate and consistently reproducible symptoms, which may affect multiple organ systems. Reactions typically occur up to 2 hours after cow's milk protein ingestion, usually within 20 to 30 minutes. Non-IgE-mediated food allergy involves a cell-mediated mechanism, and reactions are typically delayed. They usually manifest between 2 and 72 hours after cow's milk ingestion. Mixed IgE and non-IgE allergic reactions involve a mixture of both IgE and non-IgE responses, and are typically delayed. Risk factors associated with developing cow's milk allergy include male sex. Boys have a 2-fold higher risk of developing cow's milk allergy than girls in childhood. Known food allergy. The presence of a confirmed food allergy increases the likelihood of additional food allergies. Comorbid atopic conditions, such as asthma and atopic eczema. The frequency of severe allergic reactions is higher in children with asthma, especially those with poorly controlled asthma, than in children without asthma. Family history of food allergy. Confirmed food allergy in a parent or sibling increases the risk of food allergy. Family history of atopy. This is a risk factor for developing food allergies, although only an allergic predisposition is inherited, not specific allergies. Complications. The possible complications of cow's milk allergy include stress and anxiety affecting the child and parents, carers. This may be associated with the need for constant vigilance over food choices and risk of accidental food exposure and severe reactions. Reduced quality of life. Dietary restrictions affecting food shopping and family meal provision, which may be stressful and time-consuming. Impact on social interactions, such as eating out, playing at friends' houses, attending birthday parties, and participating in school meals. The impact of peer pressure, stigma, and embarrassment about food allergy. Potential social exclusion, such as not being invited to friends' houses, trips, and activities. Restricted diet and malnutrition. There is a risk of inadequate nutritional intake, malabsorption, and faltering growth in children if food allergens that contribute essential nutrients are eliminated. Development of the topic comorbidities. Cow's milk allergy may be the first stage of the so-called allergic march, and may be associated with the later development of other atopic conditions such as asthma, atopic eczema, and allergic rhinitis. Cross-reactivity of other mammalian milks. Potentially cross-reactive milk proteins may include those in goat, ewe, horse, camel, and buffalo milk. Severe and life-threatening reactions. Food allergy is the most common trigger of anaphylaxis in the community. There have been rare cases of life-threatening anaphylaxis following cow's milk ingestion in sensitized children. Enterocolitis, enteropathy, and proctocolitis severe non-IgE-mediated allergy may present as food protein-induced enterocolitis syndrome, FPIS, involving the entire gastrointestinal tract with severe vomiting, diarrhea. Hypotension and collapse after milk ingestion. cow's milk-induced enteropathy, which involves the small bowel and may cause secondary lactose intolerance, or proctocolitis, which involves the rectum and colon, causing mild rectal bleeding and mucus in stools. Eosinophilic esophagitis. This is a severe form of non-Ig-mediated allergy, typically presenting with a combination of vomiting, food aversion, and faltering growth in an infant. Heiner's syndrome. This is a rare milk-induced pulmonary disease. Severe cases may be complicated by pulmonary hemosiderosis, which may present with anemia or hemoptysis. Diagnosis. Be aware that the clinical features of cow's milk allergy are variable in type and severity and can overlap with other common conditions, so clinical judgment is needed when interpreting symptoms. Suspected diagnosis of cow's milk allergy in children who have one or more of the symptoms and signs: skin, pruritus, erythema, acute urticaria, acute angioedema, atopic eczema, gastrointestinal, angioedema of the lips, tongue, oral pruritus, nausea, colicky abdominal pain, vomiting, diarrhea. Respiratory, cough, chest tightness, wheezing, or shortness of breath. Upper respiratory symptoms, nasal itching, sneezing, rhinorrhea, or congestion. Other symptoms and signs of anaphylaxis or other systemic allergic reactions. If a diagnosis of cow's milk allergy is suspected on the basis of reported or observed clinical features, assess the child to help distinguish between Ig and non-Ig-mediated allergy and manage appropriately. Take an allergy-focused history by asking about the symptoms, severity, frequency, speed of onset, duration, and the timing of the reaction in relation to cow's milk exposure. A food and symptom diary may be helpful. Symptoms usually develop within a week of cow's milk introduction, although they may be delayed for several weeks. Reactions may be triggered by food ingestion, inhalation, or skin contact, rare. The form in which milk has been ingested, fresh, processed, cooked, or baked, and the quantity. The trigger is usually cow's milk. However, it may be cow's milk protein in maternal breast milk in infants who are exclusively breastfed, rare in Ig-mediated allergy. Ig-mediated reactions usually occur following a small amount of milk, whereas non-Ig-mediated reactions usually occur after ingestion of larger volumes of milk. Any uneventful exposures to cow's milk before or after the reaction. The setting of reactions, such as school or home. The reproducibility of symptoms on repeated cow's milk exposure. The age when symptoms started. The child's feeding history, age of complementary feeding, weaning, breast or formula fed, weight gain, and nutritional status. Most affected children present by 6 months of age. Onset is rare after 12 months of age. If the child is currently being breastfed, ask about the mother's diet. Any comorbid atopic conditions such as asthma, eczema, or allergic rhinitis, any history of other food allergies, any family history of food allergy or atopic conditions, particularly in parents and siblings, any symptom response to dietary restrictions or reintroduction of cow. Differential diagnosis. Alternative diagnoses which may present similarly to cow's milk allergy include food intolerance, a non-immune adverse reaction. For example, lactose intolerance caused by an inability to digest and absorb dietary lactose. Symptoms of lactose intolerance may overlap with those of non-Ig-mediated cow's milk allergy if there is cow's milk-induced enteropathy, and may present with abdominal pain, bile, oding, and explosive diarrhea typically 30-60 minutes following ingestion of lactose-containing. Congenital lactase deficiency is very rare, does not usually manifest before 5 years of age, and is seen in small populations in Finland and Russia, for example. Acquired or secondary lactose intolerance is usually transient, and they occur with mucosal damage due to underlying gut conditions, such as following gastroenteritis. Other food allergies, such as egg, soy protein, or wheat allergy, or allergies to other substances, such as animal dander, molds, and dust. Colic, gastroesophageal reflux disease, GORD, Crohn's disease, celiac disease, constipation, ulcerative colitis, pancreatic insufficiency, such as in cystic fibrosis, infection, for example, urinary tract infection, anatomical abnormalities, such as fossa diverticulum, intussusception, malrotation of the gut. Management of children with confirmed mild to moderate cow's milk allergy in primary care. If a diagnosis of mild to moderate non-IgE-mediated cow's milk allergy has been confirmed following a cow's milk elimination trial and subsequent home reintroduction, check whether referral to a specialist allergy clinic is needed. For example, if a child develops clinical features of severe non-IgE-mediated cow's milk allergy, ensure referral to a pediatric dietitian has been arranged, who can provide regular monitoring of growth and nutritional status, including faltering growth or excessive weight gain. Advice on a cow's milk-free diet, including hypoallergenic infant formulas and suitable substitute foods if complementary feeding, weaning. Advice on performing a home reintroduction of cow's milk, and follow-up. Advice on inappropriate dietary restriction, vitamin and calcium supplementation, and any feeding problems. Advice if the child is already on a restricted diet for other reasons, which may be cultural or religious. Advise strict adherence to a cow's milk-free diet for the mother-infant until the child is 9-12 months old and for at least 6 months, if symptoms do not improve over this time. If cow's milk allergy is no longer suspected, the mother-infant may resume normal feeding and consider referral to a local pediatric service for further assessment if symptoms persist. If cow's milk allergy is still suspected, arrange referral to a specialist allergy clinic and consider seeking specialist advice on the need to avoid soya protein and egg from the diet as well. Note: the IMAP guidance notes that in exclusively breastfed infants, the likelihood of sufficient cow's milk protein passing into breast milk to trigger reactions is low, so complete cow's milk exclusion may not be needed. Following a cow's milk-free diet, advise a planned home reintroduction of cow's milk into the mother's or infant's diet to assess if tolerance has been acquired. Note: if the child has signs of current atopic eczema or there is any history at any time of immediate onset symptoms, do not advise a home reintroduction and instead arrange referral to an allergy specialist for allergy testing and ongoing management. Tolerance to cow's milk protein should be assessed using a milk ladder and monitoring for the return of symptoms. A milk ladder reintroduces baked milk products first as heating reduces allergenicity. Once tolerance is established, greater exposure of less processed milk should be gradually encouraged, ending in the reintroduction of fresh cow's milk. The IMAP Milk Allergy Guideline Milk Ladder and Milk Ladder Recipes leaflets may be helpful for parents, carers. Advise parents, carers to have oral antihistamines available at home in case there is a return of symptoms on reintroduction. If symptoms return on reintroduction of cow's milk, a cow's milk-free diet should be continued, and the child should be reevaluated after a further 6 to 12 months. Provide parents, carers with information on sources of advice and support. Provide parents, carers with advice on food allergen avoidance, including prompt recognition of symptoms, the risks of accidental exposure, and tips when traveling.